So welcome guys to the Med Crash Course series. We're doing a finals crash course on urology today, which will be taught by Dr. Jess Caterson. So there is our email in the bottom left corner. So if you want to email in any questions that you remember later on, please do. And in the top right corner, we've got the QR code for our Instagram page. So please do follow if you don't. Cool. Next slide. There we are. Okay. So here is the QR code to the polls, and I will post the link as well in the chat, and I'll post it along for anyone who joins late. Give people a couple minutes, and if you want to start the polls as well, you haven't.
I've started the session.
Okay, cool. I'm just going to post it in the chat.
And hopefully people will come in. Okay, fine. Cool. So yeah, as I said, my name is Jess. Nice to meet the few of you, and hopefully more people as we go along. I'm an F3, just so you know where I am in my life, and I'm doing a master's at the moment. But I very much like surgery and all surgical things, and have sat many surgical exams. So hopefully I can give you some insight into urology for a finals level. I think this is all recorded, so you know, feel free to basically go through the YouTube video and get a list of everything afterwards, so you can get like comprehensive information about kind of areas to study, etc. But these are generally just the topics that I'm going to try and cover in this talk. Just a quick disclaimer, I made these slides. They are not a replacement for your final syllabus. They're not a replacement for your medical education. But hopefully, as I said, they cover a lot of the things that you did. I know finals are being more standardized, but there can still be variations. So just be aware of any local examination guidelines or things that you might need to know. I wrote these SBAs all one myself, so please don't copy them and use them in another way. I've got no conflicts of interest, and my general advice with studying for finals is these three sources for surgical stuff were really helpful. So the Cheese and Onion Oxford Clinical Handbook is really, really useful. Teach Me Surgery is constantly being updated, has great information. It also has questions that you can test yourself on. And of course, PassMed is great just to get through MCQ banks. And I highly recommend it. I depended on it, and I still depend on it to this day with exams. So we will start with SBA. So I'm going to open the first poll on VVox. So have a read of the question, and I'll give you a bit of time to answer. And if you haven't signed up, the link is in the chat, because it'd be great if all of you could join that. Okay, great, you've all answered. So I'll show the results now. Yeah, so you're all right. The answer is, the answer is C. So basically, I mean, this is a classic presentation, young person, young meaning that you wouldn't think of something else necessarily, a very short history of loin to groin pain that's intermittent, blood in the urine, and blood's otherwise pretty unremarkable. Renal colic is the answer. Next question, I'll open the poll now. And if you're not sure, just give it a guess. There's no shame in a wrong answer. That's why you're here, for me to hopefully teach you something. So. one more to answer. Okay. So the answer here is actually B, so Proteus SPP. This is just something that if you don't know, write it down. And once you know it, just memorize, memorize, memorize. And then if this question comes up, you know the right answer. It's to do with an enzyme that the Proteus produces. So it produces a urease enzyme, which increases some like chemicals which can cause stone formation. And usually it causes large stones, i.e. horseshoe calculi. And final question for this section. Again, if you're not sure, just give it your best guess. We'll talk through everything afterwards. If you haven't had a go, just give it your best guess. Okay. So the answer here, I don't think it's animating, which is annoying, but the answer here is C. So urgent nephrostomy tube and ureteric stenting. So this case it has similarities to the first one. So it's a young person with a short history of severe loin to groin pain. So that matches the renal colic. Urine dip shows microscopic haematuria. So that's just another way of saying there's blood in the urine and the patient is not pregnant, which is really important because it's a female of childbearing age. Differences now, so the patient has got a temperature in this case, and their bloods also show a raised CRP, and their CTKUB, we've already got the answer, they've got a stone. So they've got quite a large stone on the right side. And so all of this, it should be the same side as this, sorry. But so basically the red flags here are that this patient has got a large stone, so an obstructing stone, and they've got evidence of infection. And whilst the renal function is okay at the moment, it likely will deteriorate very quickly. And so this would be someone that you would consider for urgent, basically decompression. So nephrostomy tube and ureteric stenting. So as I said, these slides are going to be available to you afterwards. So please don't worry about trying to get all the information down. I've put a lot of information on the slides so that you can go back and look at it later. And this is just information from my own finals notes. So those resources that I gave you at the start are also where you can look if you want more. So for renal stones or ureteric stones, basically the most common are these calcium oxalate and phosphates, but you also get other types of stone, which usually come about because of some metabolic abnormality. Struvite or triple phosphate is what usually you get with a horseshoe calculus. And as I said, it's the urease producing bacteria, which include Proteus SPP, that typically cause these. And it's quite a classic MCQ question, so it's definitely worth being aware of. Risk factors, so not drinking enough or being dehydrated, having metabolic abnormalities, renal issues or other sort of risk factors for specific stones such as gout and ileostomies for uric stones can contribute these things. Symptoms, as I said, typically it's like loin to groin pain, it's colicky, and it's usually quite severe. And the investigation of choice is always CTKUB. You might also do an abdominal X-ray to kind of follow up down the line with to see if the stones pass, basically. The most common sites, again, this is like really useful to know for MCQs, are the PUJ, so the uretopelvic junction, the VUJ, the vesico-ureteric junction, and the point where the ureter crosses the pelvic brim. They're the classic three sites that you would find stones because they're the narrowest points. Management, again, I know it's a lot of words, so please go back and look at this later. basically analgesia is really important, and PR diclofenac is your kind of number one choice. You're going to do investigations such as urine dipsticks, bloods, pregnancy tests in women, and if you're going to do any surgical intervention, you need to do a clotting. Management generally depends on size. The one extra point, though, is if there is any evidence of infection and obstruction, it's a surgical emergency, and that's where you need to do that nephrostomy tube decompression. Otherwise, depending on the size, and it's important to know kind of the general sizes that you would choose different treatments, because that can come up in questions. So you're either going to leave it, but give a bit of painkillers and tamsulosin to help things chug along, or you're going to do things like lithotripsy, uretoscopy, or percutaneous nephrolithotomy, which are basically lithotripsy. You break up the stones to smaller sizes so they pass, and the other two are stenting to kind of relieve the pressure and remove the stones in other ways. Finally, prevention. This is more kind of advice that you would give in a setting where you might work, so say A&E. Drinking lots, changing your diet so you're not having, especially if you've got like a metabolic predisposition to certain things, you might avoid certain foods, and some medication can also help in certain situations. Okay, the next SBA, I'll open the poll now. Again, if you're not sure, just give it a go. Okay, very fun. We've got 50-50 on the right, the right general answer. So the answer here is C. Okay, I can show the correct answer. There we go. So hopefully you both clearly identify this as testicular torsion, or it sounds enough like testicular torsion that we want to jump to surgical exploration. The choice between scrotal and inguinal is kind of more related to tumours. So basically in a tumour, you would do an inguinal approach because you want to follow the embryology and the embryological origin of where the testis travels. Whereas in torsion, you can take a scrotal approach, and that way you can do a repair, which hopefully prevents testicular torsion generally happening again or on the other side. Next question. Okay. Yep, correct. So seminoma classically has this description, also known as looking like a potato, apparently, if you're into histopathology. And third question. Again, best guess is fine if you're not sure. Okay, I'm gonna So the answer here is B. Basically, in a young male with these symptoms, you would think more STI rather than UTI initially, because they would be less likely to have a UTI. Generally, doxy is a good starting point, and yeah, and doxycycline is just a good starting point. Yeah, no, well, I guess, yeah, it's urology talk, so yeah, you would think it would be urology answer, but no, we do touch on presentations that may sound like urology but might not be urology, and this is one. So yeah, in a young male, you'd be thinking more along the lines of an STI, and that's why B would be the answer of choice. C, ciprofloxacin is good for like prostatitis in older men, or a UTI in an older male. And the nitro and trimethoprim are kind of your classic UTI antibiotics for women who, well, they can be pregnant but at different stages of pregnancy. But that's beyond the scope of this talk. Fine. Oh, there we are. There's the answer. The animation worked. Fine. So talking about scrotal masses, 3 key questions that you want to be thinking in an examination, or generally if they describe an examination in any questions. Can you get above the lump? Is the lump separate from the testes or part of the testes? And what does it feel like? Does it feel cystic, so kind of a bit fluctuant, or is it solid? And depending on what it is, kind of depends on where you're going with your differential diagnoses. So as you can see here, some examples of answering these questions and the changing differential diagnoses based on that. Lots of content on this page again. Cystic feel, fluid feel, I don't know, it's kind of, well, one thing that I would say is like hard. So you get things that like soft, firm, or hard. So soft, they say touch the side of your cheek, and that's what soft feels like. Firm, feel the front of your nose, and that's kind of what like firm, or more of a cystic thing might feel like. And then hard is like feel the bony part of your nose, and that's what hard feels like, and that's more kind of tumors or more worrying things as a general rule of thumb. But obviously you're going to investigate further. You're not just going to go based just on how you feel. So yeah, so these are just a bit of information about some of those differential diagnoses, just to touch on epididymoorchitis, which is what the third one was. Doxy you might give. If you think gonorrhea, you can also add ceftriaxone, and then Cipro for older males who it might be more of a UTI than an STI, but never assume. And generally anyway, follow your local guidelines and make sure you're taking samples and culturing these things so that you actually know what you're treating and targeting in the long term. Testicular tumours. So the commonest malignancy in males aged 15 to 44, so important to know about. Generally undescended testes, even if you have corrective surgery at a young age, is a risk factor, as well as having it on family history or having a previous tumour on the other testicle. The types, so you got the seminoma, which is the one we described, or the non-seminomatous ones. And typically it's a painless lump. A lot of them present actually with METs, so 1 in 4 seminomas and about half of non-seminomatous, whenever these would have been about 5 years old at least, these statistics now, so the numbers might have gone down with more awareness. In terms of learning, I would highly recommend remembering alpha-fetoprotein and beta-HCG and LDH. So these are really important tumour markers that often come up in questions. And they're useful both before treatment and during treatment, so you can monitor progress and relapse using these blood markers. Treatment, so you need to remove the testicle, and in this case it's inguinal incision that you would do, not scrotal. And the reason is because the lymph drain, so the testes obviously descend during embryological development, and so the lymph node drainage is actually intra-abdominal, and the scrotum has a different embryological origin and therefore a different lymph drainage. And if you open up the scrotal sac, you're essentially seeding, or there's a risk of seeding the cancer to a distant site. So you could be forming distant metastatic disease where there wasn't previously. And that's why you remove it through the inguinal approach, so through the path that the testes takes to descend to where it is. And also radiotherapy and chemotherapy are important. And actually, despite the perhaps not so great numbers on METs at presentation. Survival is actually pretty good in general for testicular tumours. Torsion, so this is really, really important not to miss, and if you have a suspicion, it's really important to escalate it as a general piece of advice. So the key numbers, 6 hours is your kind of number. Time is testes, and 6 hours is the time that you really have to save the testicles. So you want to know when the pain came on, and you want to know how long you have with surgical preparation. Typically, the presentation is essentially pain, exquisite pain, and the patient is usually very unwilling to have anything examined because it's so painful. But what you might notice is that the testis lies horizontally, transversely, and it lies high, and it lies high because you lose the cremasteric reflex, basically. A big risk factor is something called a bell clapper deformity, and this is basically an anatomical variation in how the testis is attached to its surrounding fibrous tissue, and it basically means it's more likely to twist because of that anatomical variation. In terms of investigations, history is really key, because you want to kind of figure out if there's any reason why you should suspect something else, such as cancer or infection or something else, basically, because ideally you just go straight in and operate if it was a testicular torsion, but obviously if it's a tumor, for example, you don't want to do a scrotal incision. So you need to be quite sure. So if there's any reason, any reasonable doubt, so say, oh yeah, I had felt a lump before and now it's become painful, or they've got infection, their inflammatory markers are off, anything, and you can get ultrasound in good time, you might consider it, but generally you would go straight to surgical exploration in this case, compared with some other things where you probably do other investigations first. And just for treatment, generally you need to make sure that, as well as just consenting for exploration and untwisting, you also consent for possible removal of the testes if it is no longer viable, and bilateral fixation. So if you get, because of this anatomical deformity, if you have it on one side, you're more likely to have it on the other side, therefore you're more likely to also tort the other testicle. So typically they repair both sides at the same time to hopefully reduce the chance of you having it again. Great, so we'll move on to the next SBA. If you've joined us since the beginning, actually just put the link in the chat to join. Feel free, just answer them. It's all anonymous, there's no negative marking. If you guess it, it's absolutely fine. I will talk through all the answers, but please have a go if you can. Okay, I'm going to stop the poll. So this is a bit of a toughie. So the correct answer is D, immobility. So I mean, this is essentially describing acute retention. I mean, it's in the question. Benign, so prostatic disease, so cancer or BPH are both risk factors. And because of this, essentially being a male also increases your risk of having retention. And because prostate disease, especially BPH and cancer, to be fair, both come along with age, age is also a risk factor. So if you're older, you're male, and you've got prostatic disease, you're more likely to have retention. Spinal anesthesia, you're affecting the nerves that control like micturition, so urination. And so often after spinal anesthetic, people are at higher risk of going into retention as well. Immobility, it's definitely kind of all mixed in with this, but in itself is not necessarily something we recognize as a risk factor. Although if it causes constipation, then the constipation might then contribute to someone being more likely to be in retention. Next question. Cool. Yeah, so C is the correct answer. So this is a case where you've got a patient who's developing a chronic retention issue, and progressively they won't be able to pass urine for themselves. So you're not going to catheterize and then remove it, because they're going to run into trouble again. A suprapubic catheter might be something you consider down the line, but it's not what you would jump to first. Tamsulosin finasteride, monitor and reassure. Again, this is an irreversible progressive condition, so that's not going to apply. So intermittent catheterization is going to be your first choice. Okay, and last question. This one's a bit wordy, so give yourself more time. Okay, yep. I'm going to stop the poll. Okay, so the answer is E. So, I mean, unfortunately, when you do a talk about a specific topic, often the answer is kind of obvious. So, I mean, the patient is clearly, again, in acute urinary retention. The question is more the specifics now of management. So, I mean, you're not going to do A, because, I mean, we have a high suspicion that there's a lot of urine in this patient's bladder, and so giving another hour is pretty mean, to be honest. Catheterizing and then referring. So, I mean, B and C, catheterize is definitely correct. I mean, I hope that's obvious. And really then the question is, what investigations do we need to do? What might we need to also do as well as catheterize at the time or do in the future? Now, the main point of this question really is that the volume, so the fact that there's 999 plus mils, means that this patient's really gone into retention. And the risk is that when you catheterize, there's a huge fluid shift. So all the fluid comes out of the catheter, they fill up the catheter bag, 1 litre plus. And what can happen is you can get something called like post-diuresis syndrome, and basically you can get a really severe AKI. So what's really important is that when you catheterize, you always, regardless of what the bladder scan says, look at how much urine is actually coming into the bag. And if you're getting up to kind of, I don't know, 750, 800 mils to 1 litre, then you probably want to give them IV. Well, you definitely want to give them IV fluids, and you want to keep an eye on how much fluid is coming out, because what can happen is a post-obstructive like diuresis, and then a severe AKI, and then you're running into other problems. Now, of course, in general, you do need to consider, why has this person gone into retention? I mean, they're not that old, probably could have made them a bit older. And so you might consider, asking them about any symptoms that indicate they might have BPH or a risk of malignancy. And based on those, you might make other decisions, such as referral to urology, investigations, DRE, 2-week wait, PSA, and so on. But generally, there's not really anything in this to indicate that that's necessary at this point, but that's not to say that it wouldn't be necessary once you've got more information. The reason you wouldn't give antibiotics, because there's no evidence of infection. I mean, some people do give antibiotics when they catheterize. It's a bit of a mixed bag, but I think generally you just need to be careful with accidentally introducing antibiotic resistance by accidentally changing. A DRE is a PR, sorry, a digital rectal examination. Yeah, So yeah, so antibiotics, again, is context dependent, but this person has come in for an elective operation. They probably had a spinal anesthetic and they've probably got some BPH and gone into retention. So you just need to catheterize them, probably talk to them the next day, and they're home and happy. But all of the other things are certainly things you should consider, but this question doesn't necessarily indicate you should jump straight to those. But certainly the one thing you do need to do is give IV fluids based on the volume that is allegedly in this bladder. So talking about retention, so acute is when it's a sudden inability to not pass urine. It's often excruciatingly painful, and it's often quite, well, it's pretty obvious, I would say, on examination. I think I seem to have a predisposition to always being bleeped about it. So I think on one on call, within an hour, I catheterized 2 patients because they were in acute retention. So I've seen my fair share, and it has to be true that they are in a lot of pain. They are. Imagine when you're desperate to go to the loo, but you physically can't. It's literally like that. And often you can see a bladder, or you can definitely feel a bladder. And when you feel, it's even more painful. So that's often what you find. Causes, there are many. BPH is the most common, or prostatitis, other prostate issues, but there's lots of other things you need to consider. So there might be sort of a structural issue, it might be medication related, neurological, or post-operative or postpartum. So it's certainly always important to consider why someone's gone into retention. Management, do a bladder scan, but be careful with bladder scans because they're not 100% perfect. So if you clinically strongly suspect that they are in retention and the bladder scan says otherwise, probably go with your clinical suspicion. Like, it can be quite obvious. Depending on how much fluid comes out, then depends actually if they were by definition in or not in acute urinary retention. The main thing is that if you do put catheter in, loads of urine comes out, you start to think about causes and whether they need anything else. And the other thing is that if there's any complications, you might need to get urology involved to do some more complex bits and bobs. For chronic, it's gradual, typically painless, and essentially it's a kind of failure of bladder emptying. So every time you fill your bladder, you empty it, but you don't get it all out. And so slowly over time, that volume increases, and essentially that the signals for that person to say you need to open your bladder, go away. BPH is also a common reason, but you've also got the neurological causes here as well. It's really important that you do a post-void bladder scan to see if there is any retained urine and how much. Do bloods, you want to look at renal function, infection, and just be wary if there's high pressure retention. This basically means that the filling of urine is causing like pressure and backlog up the tubes. It might cause hydronephrosis. That's important to be aware of because you might need to refer on to urology. Treatment, so you start with intermittent bladder catheterization before going to indwelling catheter, before considering, say, a suprapubic catheter. The reason is because there's a lot of risks involved with catheterization. So you've got infection, you've got trauma, pain, stones, and often it gets a lot more difficult as you progress through. So you want to try and minimize the amount of catheterization someone experiences, but inevitably they'll probably have to have one permanently after a while. In men, sometimes with BPH, you can try other medications like tamsulosin or some of the hormonal medications, but it really depends on the cause as to whether medication works or whether you need to go for catheterization. Okay, next SBA. One more to answer. Ooh. Okay, You've got 5 more seconds. And I'm going to stop the poll. Okay, I'm stopping the poll. So this is a bit of an annoying one in that you either probably know it or you probably don't. And hopefully after today you can go away and make sure you know it, because it's a classic question again. So the answer is C, transitional zone. Yeah, just need to know. Next question. One more to answer if you want. Give you 5 more seconds. Okay, I'm going to stop the poll. So really good. Yeah, hyponatremia. So this is describing TERP syndrome. The big hint is they had a TERP. And so the features you get are acute confusion, hypothermia, and hyponatremia. Perfect. And this one, let me open the poll. Possibly a bit harder, this one. If you're not sure, you can guess. Okay, again, I'll give 5 seconds. Oh, I had some changing. Okay, I'll stop it now. So this one is a bit in the question wording. So Gleason is related to prostatic malignancy. It's a histological score that basically looks at the worst, basically finds the worst bits of the prostate when you take it out, and it scores them on the severity. And it helps with grading of prostatic cancer. PSA is a blood test looking for prostate-specific antigen, which is associated with prostatic cancer, but it's not 100%. So about 30% of people can, with prostate cancer have a normal PSA. PESI is for PE, so it's just completely unrelated. And the Nottingham Index is for breast cancer. It's involved in prognosticating breast cancer. So the answer is PRAD score. And basically this is looking at MRI. So I'll discuss it next when I talk about carcinomas. Essentially, it's now part of the process in deciding the risk of someone having prostate cancer and going on for biopsy and further investigation. So BPH affects the transitional zone of the prostate. Classic, too many random names for tests, yeah. I'm reading the chat, by the way, so if anyone has any questions, please chuck them in the chat. Yes, unfortunately, medicine loves giving us too many acronyms and eponymous names, and I could rant for a long time about it, but this is one of them. So BPH, another acronym. The symptoms of LUTS, another acronym, can typically cause it. So these are things that you want to look for. Investigations, a big part of for BPH is actually like how it's affecting the quality of life, because Some people can get by with it, other people might need medication or surgery. There's lots of lifestyle interventions that you can advise, but ultimately some people will need to go for medical management, and that usually comes in two bits. So you've got your alpha blockers such as tamsulosin, and then you've got the 5-alpha reductase inhibitors such as finasteride. It's really important to make clear to a patient that the latter, the finasteride, usually takes 3 to 6 months to go into effect. So the tamsulosin is kind of a symptomatic instant thing. The finasteride is a long-term benefit. Finally, if that's not working, you can go for surgery. TURP is the most common, but as you can see here, there's lots of variations of TURP and all sorts of things that they do these days. If you do have a TURP, there are important complications that you need to be aware of as medical students because they do come up in exams. TURP syndrome is classic. So as I said, hypothermia, hyponatremia, and acute confusion. But other things that are important when consenting patients are things such as retrograde ejaculation, erectile dysfunction, incontinence, and the usual bleeding infection. So prostatic carcinoma is very common, again, in men. Typically it affects the peripheral zone, and typically it's an adenocarcinoma. The symptoms are very similar to BPH. In an SPA, what would be the correct first line? The correct first line investigation for BPH, I think it's hard to say really. I think obviously if someone's coming in with prostatic symptoms, as you can see here, the symptoms are often quite similar with cancer as they are with benign prostatic hyperplasia. So you want to make sure that they don't have that. So what you might do is a PSA and a DRE, PR or DRE exam. One thing that's really important to note is that you should do the PSA blood test before you do a DRE, and you need to be really careful when you do the PSA, because PSA can be falsely raised by lots of different things. So if they've had sexual intercourse within, I think, 24, 48 hours, that can affect it. If they've done exercise, if you've done a PR exam, all of these things, or if they've got like an infection, like a prostatitis, anything like that, all of these things can falsely raise your PSA. And obviously, if you have a raised PSA, you might then be going down the track of biopsy and things, which is very invasive. So it's important that you do the blood test at an appropriate time. PR examination, of course, is important with any patient presenting with prostate symptoms as well. I'm not sure. I think all of it is kind of, I'm not sure what I would say is the first thing that you'd necessarily do. It depends on the question and the answers they have, but certainly PSA and PR exam you would want to do, because the first thing you need to do is rule out cancer really, and decide how far down the cancer investigation line you go before jumping to something else. So yeah, so prostate cancer presents relatively similarly, but things like weight loss and back pain or bony pain are more suggestive. PR exam or DRE, it feels very different. So rather than like a smooth enlarged prostate, it does feel hard and craggy. It really does. PSA is a blood test that you can do, but beware, normal does not mean normal, and raised, you need to be careful that you haven't done the blood test at a time that would be abnormally raised. And then the other investigations are biopsy and MRI. Now these days, MRI is used as a means of deciding whether someone is going to go for biopsy or not. So if you ever see a biopsy, it's a pretty unpleasant experience. So if you ever have one, I'm sure it's even more unpleasant. But as a student, you might see them doing biopsies, and it's quite invasive and painful and not comfortable for the patient. So the MRI is quite useful now because they've got this score called PRAD score. And basically, if you get 3 out of 5 or above, you're recommended to have a biopsy. Gleason score is then used to grade the cancer. And basically, as I said, you find the worst 2, and the first number indicates the one that is the most. So 8 plus 9 would be slightly better than 9 plus 8, because what that means is that most of the tissue you looked at is an 8 out of 9, and then a little bit is a 9, or sorry, an 8 out of 10, and the last bit is a 9. Whereas a 9 plus 8 means that mostly you're talking a 9 out of 10, and then a bit less is an 8 out of 10. Cool. And this, go and look at it in your own time, but there's lots of options for treatment. Typically, unfortunately, prostate cancer is found quite late, so it might be more surveillance, drugs, rather than the radical surgeries. Also, the surgeries can cover a lot of comorbidities. But yeah, there's lots of various options out there. Okay, we're on to the last bit. So let me open this poll. Okay, one more to answer if you want to. Give you a little bit more time. It's a bit wordy. Okay, 5 more seconds. Okay. Okay, so the answer is C. So this is to do with knowing NICE guidelines, really. And this general section, I would say NICE guidelines are your friends in terms of learning for MCQs and any writtens or anything else you might do, OSCEs. Age, she's 55. Number 2, she's had multiple UTIs despite treatment. C, you've got a little bit of fatigue in there. She smokes. Yeah, so they're the things really that kind of put you with some suspicion. So giving her more antibiotics, I mean, I guess we're assuming, to be fair, that she's probably been treated for these other UTIs and they haven't helped. Non-urgent referral for CTK-UB. I mean, you probably would do a CTK-UB, but you want to do it faster. 3-day course of trimethoprim, definitely not. I'm sure she's already had that. And non-urgent referral, again, the non-urgent is the problem. But cystoscopy, urodynamic studies, you're probably going to want to be doing. But you all want to do this within 2 weeks because there's enough in this history that, as far as I'm aware, would meet the NICE criteria for a 2-week rate referral. Okay, final SBA, bit of anatomy because I love anatomy. Give 5 more seconds. Okay. So you got the right side, it's the left, and it's a varicocele, and I'll explain that when I get onto the slide in a moment. So Haematuria. Haematuria can be caused by lots and lots of things. And the most important thing that you need to know is, for your MCQs and for real life, is should you be worried? Because if you referred every haematuria as a 2-week wait, you would probably overwhelm the urology service. But equally, this can legitimately be the only sign of malignancy, and it's important you act on it in the right circumstances. So some things can cause spurious microscopic haematuria. It's transient. There's a good reason. You don't need to worry. These include some UTIs, menstruation. So often, actually, when I worked in A&E, you do urine dip on someone on their period, and it would always come back with blood, which made it hard to interpret if you were thinking about like renal stones, things like that. Vigorous exercise. So if someone's gone and run a marathon or an ultra marathon, something like that, they might actually have some microscopic haematuria just from like trauma and sexual intercourse as well. Things that can cause it, but it persists. One is cancer, and that can be in the bladder, in the kidney, or in the prostate. There are other things, so kidney stones, BPH, sort of more chronic infections, or intrinsic renal issues. And then you get your spurious causes, always to be aware of. So, you know, it's worth asking patients, have you eaten things like beetroot, rhubarb? Rifampicin, which is for TB treatment. It looks, if you've ever seen it, it's literally like bright red, and it legitimately makes your fluids bright red. And doxorubicin is another one. So dipstick helps you figure out, is it actually blood, is it not blood, whether you can or can't see it. Persistent non-visible hematuria is technically defined as having multiple tests over a multiple time period and them having blood in it. If you're worried about renal issues, you might also do some more specific renal tests, and microscopy can also be of benefit to have a look at, you know, the blood cells and how many there are. So NICE guidelines say visible hematuria over 45. Okay. Oh, you've jumped ahead. You've just written my next slide for me. So no, it's fine. So yeah, so NICE guidelines for hematuria referrals. This is kind of really what you want in your head for MCQs and for life. So if you are over 45, you can see blood in your urine and there's no evidence of infection, refer. If you can see blood in the urine, despite so successful treatment of UTI, I would generally define as you've given them an expected course of an antibiotic. Probably say you culture the urine, it comes back with E. coli, you can see it's sensitive to, say, nitro, and you've given them 3 or maybe 7 days of nitro and they still have blood in their urine, then you refer. So that would what I would say. Successful treatment, as in you have given an antibiotic that should work, or even in the first urine dip, you've got, say, positive nitrites, leukocytes and blood, and then the subsequent one, your leukocytes, nitrites have settled, but the blood is persistent. They would be reasons. So you don't, it's not about like treating over and over again. I think as soon as you get into, you know, a week or so and you've still got blood, especially if it's visible, then jump. So yeah, and then so in terms of the technicality of non-visible hematuria, so if you're over 60, you don't have visible hematuria and you can't really explain it, then you'd be jumping to referral. I mean, this thing of like measuring it 2 to 3 weeks later, I think you'd have to have a pretty strong suspicion of something else being the cause before possibly going to refer. I'd say, and you know, it's difficult. I'd say the MCQs that you get are likely to be kind of be strongly skewed towards one or the other. In real life, I mean, it's hard, it's clinical judgment, error, the sign of caution, but unless you've got really good reason to wait 2 to 3 weeks, I'd probably start the process. And then, yeah, non-urgent referral is the other option. Fine. So urological malignancies, very quickly before this ends. So renal cell carcinoma accounts for 90% of renal cancers, mostly kind of middle age, mostly men, and hemodialysis is a big risk factor. Risk factors, so here, smoking, male, genetic, and end-stage renal failure. Symptoms often minimal, unfortunately. So sometimes things like the left testicular varicocele can be one of the few indicators for it. Treatment, remove the kidney if you're lucky. Otherwise, you can do cryotherapy, radiofrequency ablation, but unfortunately, RCCs are generally quite chemo-radio resistant. So if it's metastatic, the prognosis is poor. Bladder cancer, transitional cell carcinoma is the most common, and you might get that in an MCQ. Other possibilities you can get, there are adenocarcinoma, squamous cell carcinoma. Symptoms are similar-ish. Associations, again, smoking. Classic MCQ is aromatic amine. So if you've got a patient working in the rubber industry, think bladder cancer. Chronic cystitis or schistosomiasis. So kind of, this is like chronic irritation of the bladder wall can basically contribute to cancer. If they've had radiotherapy for some other reason and some other drugs, cystoscopies, so viewing the bladder is with a biopsy is diagnostic, and you'd also do, and then again, treatment is surgical or palliative depending on disease extent. Sorry, the patient in your question has blood plus, but no mention of visible haematuria. To be fair, it's probably my question wasn't specific enough. I would say here the big thing is that she has got recurrent UTIs and they haven't been explained. I probably should have said that she had visible haematuria, admittedly, yeah. So that's probably just the vagueness of my question. So I'll probably change that for next time, but you are right. It's, you know, blood plus may not be visible. If I'd said visible haematuria, it would have been a lot clearer. So just quickly on the anatomy, sorry, it's in another language, but that's what was free on the internet. So basically the left-sided gonadal vein joins the left renal vein and then drains into the IVC, whereas on the right side it directly drains. So if you have a mass in the kidney, it can compress on that gonadal vein, and therefore you get a backlog, and that causes a varicocele, which you can get on the left side. Great, so that's actually the end of the talk. If you have any other questions, feel free to chuck them in the chat. I think with that MCQ, probably it was a bit borderline, but the recurrent UTI plus persistence of blood is, and the age is why I went for referring. But always, just if you learn the NICE guidelines, typically the question should be clearer enough to make these things hopefully answerable. If you want to email me about anything that I've covered, feel free to email me on my NHS email, or if you have any other questions, I'll try to email them. They're my other contacts. And please, for Atch and co, fill in the feedback form and keep an eye out for the rest of their presentations. They've got a range of people speaking. I know some of them and they're very, very good. So I highly recommend going along to them. I will be doing some more surgical ones soon, so TNO, plastics, ENT, and Atch will advertise them in due course. So yeah, I'll stick around for any questions for a bit, but yeah, please fill in the feedback form because it's really, really helpful for myself and for the whole team.